Mm.
So we'll be starting in just a few moments. We have our keynote speaker with us.
Yes, this is a temperate area in more of a tropical or a subtropical India. And we have our weather, which is very much like you have in the North American areas, and very much have the same seasonality, not only in terms of geography and climate and weather, but also probably in terms of disease. And I'm going to talk about influenza today, and that you'll see will be replicating what you have in the North American regions and probably in the Western region.
Thank you, Parvez.
Thank you.
Thank you. So it's now 7 o'clock. Welcome to IFA's virtual town hall on COVID-19 and older people. My name is Andres Stenku, Project Officer with the International Federation on Aging, and we'll briefly review housekeeping. A reminder, this town hall is recorded and streamed live on the IFA Facebook page. This town hall begins with opening remarks, followed by a moderated question and answer session. Please use the chat function along the bottom of your screen to indicate that you have a question or comment, and we will call upon you to pose your question directly to our speaker. If you have resources to share, please post them in the chat as well. And resources will be compiled at the end of the town hall and posted on the IFA virtual town hall resource page. Following this town hall, you'll receive an email with an invitation to the next town hall in the series and the resources compiled. And it is now my great pleasure to pass the floor to IFA Secretary General, Dr. Jane Barrett.
Good morning, good evening, and good afternoon, everybody. We're going to just do something a little bit different at the beginning of this town hall because it's important for me to thank the IFA staff, and in particular Andra Stanku and Chesley Ryder. You know, before Andra has been leading the town halls now for how many weeks, Andra?
36.
36 weeks, with the support of Chesley Ryder, Communications Manager. So thank you for your diligence, your commitment, and your stickability, you know, against all odds. So thank you for that. Also, I want to just let you know that because there's been unprecedented interest in these town halls, you know, nearly 7,000 people have either been part of the town halls that we're here today or viewed them through Facebook. So that's certainly a lot of eyes and ears that have been part of these town halls. So with that in mind, we're going to continue the town halls into next year. But they won't be called COVID-19 and older people. Although COVID-19 may be, you know, part of the conversation, we're going to commence on January the 8th, and we're really delighted to be in conversation with the UN independent expert on the enjoyment of all human rights by older persons, and that's Claudia Mayer. So please register and join with us on the 8th of January after you've had some break from town halls and hopefully some enjoyment with family and friends. So thank you for that. It's now my pleasure to introduce Professor Parvez Cole. Professor Cole is the head of internal and pulmonary medicine and chief of clinical research at the Institute of Medical Sciences in India. Professor Cole and I met some time ago at a meeting in Singapore, and I learned a lot about how vaccinations, you know, are administered in India and what the challenges were. So we felt that as we're in the heart of the vaccine development and the distribution of COVID vaccines, we felt that it was really important to get a different perspective from Professor Cole from India. He's a medical doctor specialising in pulmonary, critical care and sleep medicine, and was ranked in the top 2 of Stanford's University list of global researchers for 2020. So we're indeed honoured for him to be with us. Professor Cole has presented in over 500 international fora and published over 350 journal articles and book chapters. He's a member or fellow of the American College of Physicians, American College of Chest Physicians, Royal College of Physicians London, European Respiratory Society, Indian Chest Society, Indian College of Physicians, and serves on the National advisory group on immunisation. And that's a very, very important group. So I'd like to hear from that, hear from Professor Cole about that. And also the Ministry of Health and Family Welfare with the Government of India. We're indeed honoured to have you with us today, Professor Cole, and I hand the floor to you. Thank you, sir.
Thank you, Dr. Barrett. Thank you, IFA, for having me here for this important town hall. And it's been a pleasure to be interacting with you. Can you see my screen?
Yes.
Is it visible? Yeah, thank you.
Thank you.
So getting you greetings from Kashmir, which is the top north of the Indian subcontinent. And we have a temperate climate, as I was talking to you, in a most tropical or subtropical country. And I've been tasked to talk about overcoming challenges in adult immunization of influenza, and my focus would be India. And I again would like to thank IFA for having me here. Immunization, as we know, is one of the most successful and cost-effective public health interventions saving disease, and it saves up to 3 million lives every year. And it is exemplified by a significant reduction in all vaccine preventable diseases that has happened from the baseline of 20th century to now, causing nearly more than 90% reduction in the morbidity and near virtual elimination of diseases like smallpox and poliomyelitis from face of most of the countries of the world. And we are in bad times with the novel coronavirus still infecting thousands of people every day. Public health officials worry that a bad flu season that we expect now could overwhelm hospitals, clinics that are already stretched thin. We know that seasonal influenza affects 5 to 10% of the world's population every year, with 3 to 5 million severe infections and an approximate estimate of 250 to 645,000 deaths every year. In USA alone, the deaths amount to about 36,000 per year, and it has a huge cost to the exchequer. Looking at the global scenario of influenza in the 2019-20, as you can see that globally there has been a predominance of the influenza activity in the early part of the 2020 and the later parts of the 2019, and subsequent to that there has been a relatively low activity of influenza all across the world. And this influenza activity has been majorly contributed to by the northern hemispherical activity, with very little of activity in the northern hemisphere beyond the 14th week of this year. And in the southern hemisphere, as you can see, the numbers are very minimal compared to what you see on the y-axis of the previous two graphs. And as you can see that despite the fact that we have had small numbers even in the winter months of the northern hemispherical region, in the southern hemisphere there has been hardly any activity during the summer months of the northern hemisphere, which is usually the winter there, and there has been a subdued activity of influenza all through the southern hemisphere. And this is exemplified beautifully by these charts from the CDC. As you can see that in the southern, this is the Australian circulation compared, this is the 2020 circulation compared to the 2017, 18, and 19 circulation. As you can see, there has been hardly any circulation of seasonal influenza in 2020, and that has been mirrored by similar findings in Chile as well as in South Africa. So there has been a subdued or hardly a minimal activity of seasonal influenza in the years of normal activity in the southern hemisphere. So coming to India, so the focus of today's talk is influenza a problem in India. There has been a scant literature on influenza from India. And there's a throwback picture of Spanish flu, which has been supposed to have claimed 50 to 100 million lives in 1918 to 1920. And if you look at one country that was worst affected by the 1918 pandemic of influenza, India was the country. More than 15 million people perished in a short span of about a year, and it was the single worst affected country in terms of total mortality. And India normally has a high population growth. And this is the only time in the recent history that we have had a negative growth in the population. However, after that, there has been limited data about influenza in India and has been mostly concentrated around study of epidemics and outbreaks till around 2004, when there was a consortium called a cooperative agreement that was inked between the CDC of the USA and the Indian Council of Medical Research. They looked at a strain surveillance of influenza across the country. There were 8 regional centers were created, and they would look at the influenza surveillance, looking for the strains. And we were a part of it. And as a part of this consortium, we demonstrated that pandemic and seasonal influenza viruses do cause acute respiratory illnesses in Kashmir. We also studied certain outbreaks. And in this particular case, we looked at an outbreak of influenza B. Then subsequent to that, we had a resurgence of pandemic influenza in 2012-13. And we also demonstrated an outbreak of severe influenza in North India. And that was related to the emergence of a new grade of AH1N1. On the countrywide scale, we demonstrated that in various regions where we were doing the surveillance of the strains, we demonstrated that there was a dynamic seasonality of influenza. And that was different in different states of the country. And the pattern of circulation was different in different parts related to the monsoons. Influenza, we also demonstrated, was causative in a number of hospitalized community-acquired pneumonias. And as you can see that after Streptococcus pneumonia and Legionella, influenza stood out as the 3rd commonest pathogen in causation of community-acquired pneumonia in hospitalized patients, as also in cases of acute exacerbation of chronic obstructive lung disease. We can see that there is a winter peak of respiratory cases, and influenza does contribute to a significant number of these exacerbations. We also found that influenza causes a number of respiratory illnesses in pregnant females, and they not only have severe outcomes in terms of hospitalizations, they also had severe outcomes in terms of deaths. Looking at the scenario of influenza in India, as you can see that there are nearly, in the COVID times, there are nearly 10 million coronavirus cases with about 150,000 deaths, as you can see from the graph here. Seasonal influenza activity has been rather low. In fact, hardly any seasonal influenza cases have been seen in 2020, which is normally a time of a high activity across the country. We also have a unique problem. India geographically is located in the northern hemisphere, so we expected a normally northern hemispherical kind of an activity of influenza. However, when we try to study 2 cities which are nearly just 500 miles apart, Delhi, which is the capital city of the country, and Srinagar, which is the capital of Kashmir, we found that there was a starkly different circulation of influenza, with Srinagar demonstrating a northern hemispherical kind of a seasonality, whereas Delhi demonstrating a southern hemispherical kind of a seasonality. And this influenza equator, which is normally the geographical equator, is no longer true. It doesn't show that the seasonality is dependent on the geographical equator, but there is something like an influenza equator, which is at a 30-degree latitude. Anything north of this influenza equator would have a northern hemispherical seasonality, whereas the rest of the country, which is south of this 30-degree latitude, exhibits a southern hemispherical kind of a seasonality. And that was published subsequently by us. And it has an influence on the vaccination timings across the country, because India doesn't behave as a single circulation pattern. It behaves, staggers different circulation patterns. And as a result, vaccination timings have to be timed according to the seasonality of particular states. And we know that influenza vaccination is a very important intervention leading to a reduction in the likelihood of developing influenza illness, requiring a medical visit, reduces the severity of disease in those who do develop influenza, and reduces the likelihood of transmitting the infection to others. It also reduces the risk of influenza-related pneumonias, hospitalizations, as well as influenza-related deaths. So it's a very desirable medical intervention. Unfortunately, this is the data from the CDC. As you can see, in adults, the percentage of uptake of influenza vaccination ranges from 32% to 72% in the elderly. However, in influenza, in India, influenza immunization is not included as a part of the national immunization program, what we call the universal immunization program. And it is recommended only for healthcare workers and pregnant females in high risk cases, but is not supported by the UIP. That's the And if you look at the physician society and bodies, they have actually woken up to the challenge of influenza only recently. And we came up with these, with the Association of Physicians of India, we came up with these recommendations only in 2016. And other bodies like the Indian Chest Society, the National College of Chest Physicians, apart from Indian Academy of Pediatrics, which came up with the vaccination schedule for their children in 2013. Rest of the societies, the physician societies of India, have actually come up with the recommendations for treating their or for vaccinating their for the vaccinating the patients in their domain only very recently. As a result, the uptake of vaccination in India in adults is very poor. As you can see from these publications, we found that the vaccination rates in Indian adults with comorbidities, be it COPD, be it diabetes, be it physiological state like pregnancy or chronic heart failure, the vaccination rates range only from 0 to maximum of 9% in diabetics. We know that the greatest influence on adults' attitude or decision to get immunized is influenced by a personal physician's recommendation or that of a family member in about 90%. Celebrity physicians or public figures also contribute to about 7% of the times to the decision. So we wanted to look at what's the knowledge, attitude, and practices about the seasonal influenza vaccinations among the healthcare workers in India, in Srinagar. And we looked at around 1,400 healthcare workers, and only 4.5% of them were actually vaccinated. And despite the fact that they knew that influenza vaccine was available and it was a possible cause for a severe disease, a number of them, most of them had not received it. And once we asked them what was the reason as to why they had not received the influenza vaccine in the past 5 years, some said that I did not believe the flu shot is effective, I did not know about the flu vaccine, side effects are unpleasant, vaccine might harm my health. Sometimes somebody said that there was no time to get the vaccine, I'm not at risk of getting influenza, and some even said that influenza is not a serious illness to the staff. And some gave other reasons, which included allergic to egg yolk, don't want to get sick, have an overactive immune system, and a lot of people get flu even though they have got the flu shot. The majority of them believe that the influenza vaccine is safe. Some of them, that's 83 of them, actually said that it may be unsafe because a physician told me so, or an internet site indicated that vaccine is unsafe, or I know somebody who has been harmed by the vaccine. It might weaken the immune or the joint systems, and I can avoid the vaccine because I have allergies. So influenza vaccination in India has lots of challenges. There's an inadequate and patchy surveillance. There seems to be a disconnect between perceptions and practice. People believe, the healthcare providers believe that influenza is a potentially dangerous disease. It can lead to serious consequences, and influenza vaccination should be prescribed. However, they do not prescribe it. There are misconceptions and misperceptions about its safety and efficacy. Physician societies and bodies do not universally recommend vaccination. And as a result, universal vaccination programs do not recommend influenza vaccination, even in children. And that might be partly related to the fact that cost is an impediment because India is not a developed or economically well-cushioned country. And influenza vaccination across the country has got to be timed differently for different regions of the country, as I said earlier. However, the biggest impediment for the vaccine hesitancy and the anti-vaxxers having a good voice is the poor sensitivity of the healthcare providers. Once the doctors don't write a vaccine, obviously patients will never take it. Celebrity vaccine campaigns would certainly help at times, like in this case, President Obama receiving the vaccine, and the recent announcement by 3 ex-US presidents that they would take the COVID vaccine if and when available. So the strategies for improving adult influenza immunization in India would need to target local surveillance data. We need to know exactly how is the influenza seasonality in a particular region so that we can target the vaccination accordingly. Adult immunization has got to be taken up formally as a part of the universal immunization program by the Ministry of Health and Family Welfare. Sensitization of healthcare providers is of paramount importance. We need to have better awareness and aggressive advocacy, which is run through campaigns, programs, and reminders. We have to involve community, and community participation has got to be there. Non-governmental organizations and governments have to partner together to increase the uptake of influenza vaccination. Cost reimbursement and involvement of insurance agencies. Most of the Indians are not insured, and as a result, there is no reimbursement of the cost of the vaccine, and everybody who has to get a vaccine generally has to foot the cost of the vaccine himself. Then we have to have a greater uptake amongst medical healthcare providers, and signed declination could be employed for those who refuse to get vaccinated. So flu vaccination is more important than ever in 2020. It could save lives. I mean, it would actually make people understand. If you tell them that there are only over 34,000 people died of influenza last year, and nearly 500,000 were hospitalized. Flu vaccination is effective in preventing the most severe forms of flu. We need to protect our community, and flu and COVID can actually coexist. And if they circulate together, our health systems are going to be overwhelmed. And there could be chances that a person could get both flu and the COVID-19 at the same time. It is free. This is a slide of the University of California, and this part is not true of in India. But there are certain states that are actually providing vaccine free of cost. So the benefits of flu vaccination, like in 2018-19, about 50% of the US population chose to get a flu vaccine. And this prevented an estimated 4.4 million flu illnesses, which is more than the population of, say, Los Angeles. 58,000 flu hospitalizations were prevented, which would be about the number of students at the Ohio State University. And 3,500 flu deaths were prevented, which would be equivalent to saving lives, about 10 lives per day over the course of a year. So let's not wait, get vaccinated. Thank you for your kind attention.
Thank you very much, Professor Cole. And we now welcome, questions. Yeah, perhaps if you can stop sharing so that we can. Okay. Good, great. What a wonderful presentation, but it really raises many, many questions, doesn't it? The first question that I've really got is, can you just tell me who does administer vaccinations, in India? Does it differ from state to state? Can you just give us, because the reason that I ask that is that, in Canada, we know that some provinces, pharmacists can administer shingles, but can't administer something else. So what's the landscape in terms of, who can administer adult vaccinations?
So vaccination programs in India have majorly two limbs. One is the governmental route, and other is the private partners. In the government vaccination programs, there is a streamlined system of vaccination, which is very robust, but it administers only those vaccines that are a part of the universal immunization program. And there is a robust system for that, and that's publicly funded. However, there is a parallel system with the private system of administration, which is run mainly through the clinics of doctors. And doctors have their pharmacies that administer vaccination to the patients coming to them for medical care. These are the two major systems of administration of vaccines. However, pharmacists are allowed to vaccinate people in terms of, or in times of, say, influenza season. Influenza vaccine can be prescribed by a doctor, and a patient can have it at the pharmacy as well. However, the cost of the vaccine has got to be borne by the patient himself.
And look, it may be a question that you're not able to answer, but what's the cost of the influenza vaccination in your state, for example?
So I would say that would be around 1,500 to 2,000 rupees, which would around 70 rupees would be a dollar would be around 70 rupees.
Right.
So it goes around 1,500 to 2,000 rupees.
Okay. All right. And that's significant, you know, for some.
It is very significant in terms of the economic cushion, because not many people can afford it.
Andra, your question.
Thank you, Jane, and thank you so much, Professor Cole. My question is around the great diversity that exists, you know, as you mentioned, across states, but also within smaller localities, in terms of different languages that are spoken, and perhaps the different levels of functional mobility of older people. I'm wondering, how can access to the vaccine be improved to reach those individuals that maybe have greater physical barriers to receiving the vaccine? And in terms of vaccination portals, I'm referring to, you know, the actual location where vaccines are administered. Is there an opportunity to expand that?
Thank you. Yeah, I think that's very, very important. I mean, very important it is to understand that the two limbs of vaccination programs that I talked about, you have to have a fortification of the government or public system. That is very important. And I happen to be a member of the National Technical Advisory Group on Immunization for the Minister of Health. And we prioritize vaccinations for a rollout across the country. And in our case, the problem is footing the bill of vaccination. For example, this time we are having a challenge of the COVID-19 vaccination, and we have to think of vaccinating 1.4 billion people. And that is the kind of a staggering cost that we are looking at. Similarly, to include vaccines gradually into the vaccination program, it requires a lot of funding. And unfortunately, as a result of poor funding, we have to be vaccinating people in a phased manner. And that is one part of it. Second part of it is that there is insurance now coming in, and they are insuring some people who are in corporate offices or working in hospitals. So they also vaccinate a part of their teams. And there are lots of people who are working in occupations where there is a high risk for developing a vaccine preventable disease. And those companies do take care of their employees. And third is there is another group of people who have to foot the bill of the vaccine if they can afford it. And that leaves still a large chunk of people who simply cannot afford it.
You know, Professor Cole, I wanted to go back to the number. You know, you said 1.1 billion people.
1.3 to 1.4 billion.
What, you know, and I think sometimes we skip across those numbers, but we need 1.3 to 4 billion people need to be vaccinated in India. I mean, yes. You know, it's really staggering, not only the cost of it, but the whole logistics. You know,
absolutely.
You know, it's so Cynthia, you've got a question for Professor Cole.
Yes, thank you, Professor Cole. It was a fascinating presentation. On one of your slides, and I don't remember the exact one on India, the age groups were under 18 and then the middle age group, and it went 50 to 64. And I was wondering, do you not collect data beyond age 64? And a second question I have in thinking about overcoming the resistance to vaccines is, any consideration given to utilizing retired physicians to be spokespersons and communicate in villages and towns of the safety and importance of vaccines?
So two things. One is people around more than 64 years of age. That particular slide was from the CDC that you were referring to. However, coming back to India, the longevity, the life expectancy of people in India has actually registered an increase from 1990 to last year, which we published as a part of the global burden of disease. Now in India, males can expect to live up to 67 years of age, whereas females have a life expectancy of about 70 years. So that is the, and older adult in India is anybody who is beyond 50 years of age. So for all programs, cutoff is around 50 years of age, and for all vaccination recommendations that have been put forth by the various physician societies, they have taken the cutoff of around 50 years. So yes, we do collect data, and geriatrics has come as a specialty very recently and has been accepted as a major specialty by the Minister of Health only very recently. And now we have regional geriatric centers that have been set up across the country in various regions. And talking of the vaccine champions, yes, there are programs and campaigns being organized about vaccinating, importance of vaccination, and these are mostly by physician societies, and there is a robust geriatric society of India as well as an Indian Academy of Pediatrics, both of whom do partner in advocating these vaccination programs. Yes, but there's still a lot to be done, and it's just not adequate as it.
So Professor Cole, I'm interested as to, your background. You're a pulmonologist, and pulmonologists don't necessarily be champions for vaccination. So what has drawn you, to be one of the leaders, and spokespeople for vaccination? I think it's important because IFA is constantly trying to reach across to different professional organisations and patient organisations. So what's drawn you to this area of speciality?
So in pulmonology, I mean, we have a very huge burden of chronic obstructive lung disease, which is one of the highest in the world. And we had patients coming to us with acute exacerbations, and we found that over a period of time, I found that they hardly have any history of vaccinations, either for influenza or pneumococcus, two of the most important pathogens causing exacerbations and disease like pneumonias in them. So that got me interested in getting some way, getting them vaccinated somehow. And that is actually the start of my interest in vaccinations. And that's how it actually, over a period of time, got bigger and bigger, and my interest got more focused towards vaccinations.
Well, we're very grateful that you're interested. I'll call on Maria Peluso for her question. Maria? Just unmute, Maria.
Okay. Thank you. Thank you so much for really an enlightening presentations on vaccinations in India. And I'm just wondering, and I think you're one of the best to ask this question, about the diversity between populations in India, and not geographically so much in the physical sense, but between rural and urban, whether there is a marked difference in vaccination rates. And as well, what would be interesting, I'm just curious, those people who are financially able or wealthy or economically advantaged, however you want to put it, is there any information, or can you shed any light on whether those people are more inclined to get vaccinated, or is there no difference between class and vaccination rates? Those kind of two combined questions.
Thank
you. Thank you for those two questions. And yes, it's talking of vaccinations in rural and urban areas in India. there is clearly a difference in people who have a deeper pocket. Those who have a deeper pocket are able to get vaccinated outside of the universal immunization program. And I tell you that adult immunization is not a priority for the country as yet. Still, the vaccination program is focused on the pediatric population. And there are very many vaccines, even in the pediatric population, that are a part of the national immunization programs across the world, but are still not enshrined in the immunization programs in the country, in India. So yes, for people who have access to greater, deeper pockets, they do get vaccinated more often than those who, though I might not have the concrete numbers, but than those who do not have deeper pockets. However, if you look at the national immunization program, the vaccines that are contained in the universal immunization programs, their uptake is good across the board, be it the urban or the rural areas, because that system of administration is more robust.
I see. Thank you.
So, Professor Cole, I'm really curious about the family structure in India, you know, the intergenerational opportunities to share the importance of vaccination. Is that one entry point that could be explored? Perhaps it already is.
It probably already is, and yes, it could be something that can be explored and actually expanded on, and then get slowly the vaccination canvas as broad as possible.
Okay, another question relates to long-term care. You know, COVID has brutally exposed, you know, some of the inadequacies of some long-term care systems. And I say some and some because it's not always the case. In some countries, the rates of cases for COVID have actually been very low. And in some countries, they've been almost non-existent. But in terms of vaccination and long-term care facilities, people in long-term care, are there any, you know, areas in India where this is seen as good practice, or is it just we're not there yet?
Yeah, I think you rightly put it, we're not there yet. I mean, long-term care facilities are not very common in India. You don't have, I mean, the family structure as we have it is that most of the people live together. There are generations living together, and you would have 2, 3, 4 generations actually living in the same family. However, it's actually changing, I mean, with time, and now we have people moving out of houses, especially from the rural backgrounds, and going to the urban areas and living separately from their parents or their grandparents. And that, however, long-term care facilities for the older adults and those who really require are still not in, and we're not yet there. We don't have too many long-term care facilities. If I name Kashmir, we have no long-term facility here, care facility for older adults, though we have some orphanages, and they're there, but generally they house only the pediatric population till a certain age, once they're able to take care of themselves beyond, say, 18 years of age. But long-term care facilities for older adults do not exist in a great proportion in India.
What's the population of Kashmir, Professor Cole?
It's nearly 12 million to be precise.
12 million, okay. These are very big numbers that, you know, clearly I can't get my head around. You have studied widely, you know, internationally, and continue to do that with colleagues around the world. So what lessons could we be learning from what's going on in India? Because I'm always conscious that, you know, that the high income countries, you know, are saying that, well, low and middle income countries can be learning from us. You know, sometimes it actually is back the other way. So I'm wondering whether, you know, are there lessons that we can be learning in terms of, you know, the way that you work in India that we can, you know, think about in other more higher income countries?
We work in penury. I mean, at times we are disadvantaged in terms of our cushion for good research, and that has to come from funding agencies, and our funders are not that cushioned either. So international collaborations would be something that would be of a mutual collaborative benefit, and that is something that we can work on. And not only that, you could look at the behavior of people. I still believe that the family system that we have in practice in India is not something that you need to deprecate. That is something that you can probably imbibe, because we have a greater social support, a greater cushion. I mean, I tell you, we have a person who is admitted to the hospital. There will be 10 people who would go and look at him and visit him and find out whether he is well, and call upon him, which is a rarity, as I have seen in the US when I was there. So yes, those are things that actually could be imbibed. I mean, there are certain cultural and social practices that could be actually taken back from the East to the West. However, in terms of advantages of the advances in the medical system, I think we have to go the other way around. It has got to come from the West to the East.
Just last week, the United Nations announced that it will be pursuing the decade on of healthy aging, 2021 to 2030. And that came from the leadership of colleagues such as Alana Officer and her team at the WHO, with extensive consultation across, the regions and at a member state level with the United Nations. So with this in place, how do you think we can use the decade to leverage, advocacy within India to support a healthy aging approach through an immunization framework? It's a big question, I know.
Yeah, I mean, it's big, and it has actually to be fielded very cautiously across India. And I tell you that one of the major pillars of healthy aging is, of course, immunizations and vaccinations, and that is something that we can build on. There is a focus on exercises. There is a focus on greater participation of the older adults in various programs rolled out by the government of India. But I think immunization is something that has greater takers in the medical community, and medical staff is someone who actually is listened to. Somebody says that you give it. I mean, I'll give you an example. I mean, we looked at pregnant females, the vaccination uptake of pregnant females in terms of influenza vaccination. We surveyed about 1,000 females, and none of them were vaccinated against influenza. And contrast that with another vaccination, say hepatitis B and tetanus vaccination, which is routinely administered here. The vaccination uptake was 100%. So I believe that if we have an opportunity of advocacy through healthcare providers, that would be the strongest point to roll out any kind of a program on vaccination.
I think that's a really important point. And I know that the world is looking at who can be the vaccinators, and healthcare professionals. Certainly, it's important that they're fully educated and up to date with vaccine schedules. One last question before we move towards wrapping up, and it's about the COVID vaccine. You've just said, 1.3 to 4 billion. What's the future of COVID vaccines being administered in India? We see, slowly starting in the United Kingdom, slowly starting in the US and in Canada. What are your thoughts about, the future of COVID vaccines in India?
So COVID-19 is a real big problem in India as well, with India in terms of absolute numbers having the second largest number of cases in the world. However, there will be logistic issues in rolling out of mRNA-based vaccines, say from Pfizer or the Moderna. vaccine, because you need logistic facilities of being able to preserve them at -70, or in case of Moderna vaccine at -20. That kind of a logistics would not be possible for India. And so as a result, I do not see Moderna or Pfizer vaccines coming to India. However, there is the Oxford vaccine, which is being developed in conjunction collaboration with the Serum Institute of India. They are actually working together, and AstraZeneca, they are developing a vaccine which would be probably more, I mean, it would not require those deep freezing and for preservation, which would be stable at 2 to 4 degrees of centigrade, which would be the usual for other vaccines. And that kind of a system is very robust. India is actually pushing very hard in terms of in developing keeping the logistics ready for rolling out vaccination. However, it has got to be a vaccine which is more stable at higher temperatures, and I see Oxford vaccine as the AstraZeneca, and there's two other candidate vaccines which would be stable at higher temperatures. One is from indigenous from Barrett Biotech, and then we have another vaccine which is with Dr. Reddy's lab in collaboration with the Russian manufacturers of the Sputnik vaccine. And there is another vaccine which is mRNA-based Indian indigenous vaccine that is still in phase 1, phase 2 trials, and is supposed to be stable at 2 to 4 degrees centigrade. So as a country, we are not into Pfizer or Moderna vaccines that might have few takers, say in few corporates or hi-fi hospitals, but otherwise for a countrywide rollout, Moderna or Pfizer vaccines would not be there. There will be probably a vector-based or virus-based vaccine, which will be more stable at the temperatures which our logistics can support.
Professor Cole, I'm just going to put you on the spot for a moment, because I'm regularly asked whether I would have the COVID vaccine, right? So I ask you, would you have the COVID vaccine?
I'm a part of the regulatory system in India as well. So if we have the data, which is actually convincing enough that it is safe and it is effective, then probably we'll go for emergency use authorization. And once we have it, if I prescribe it for somebody else, I would better take it myself as well.
Thank you very much. And I feel the same. If the science is there, and it's recommended by the regulatory bodies such as NITAGs and those that you sit on, absolutely. Who am I to say anything less than science does talk? So thank you for that. I'm going to give you a few minutes, because we're going to come back to you and ask you to take us away at the end of this year with your final messages. But I do want to say to everybody on this town hall, those that are live streaming with Facebook, and those that have been with us for 37 weeks, thank you. We came together to have these town halls because, you know, I and the staff felt that, you know, as colleagues, we were actually quite disconnected around the world. And part of our mental health and well-being, I felt that it was really important to see, you know, community. For those that don't know, I travel 6 months a year usually. And so this is the first time ever that I have been in one place for the 18 years that I've been the Secretary General of the IFA. And that's been an extraordinary time and challenging. So you have become part of my family every Friday. I've learnt a lot. I've cried sometimes on some town halls because they've been so powerful in their messages. You know, I've heard personal stories, professional expertise, professional input, and I've loved every one of them for all different reasons. And so from me to you, thank you for being part of my community and my family every Friday. Because going forward, you know, community is where we're at, you know, whether it's small, medium, large, you know, international, we are community. and we're all doing the same thing, and that is being part of the lives of one another, but also working to improve the lives of older people. Next year is like no other, 2021. I will never be here again with 2021. But 2021 also opens up the door to the Decade of Healthy Aging, Immunisation Strategy 2030, the high-level political forums at the United Nations, the 11th Open-Ended Working Group on Aging. The World Hearing Report will be launched next year, the World Vision Report, and all of these bodies of work speak to improving the functional ability of older people. And then, of course, we have, you know, the social, the physical, the emotional well-being of all of those around us. Over the course of this year, people that I love very dearly have died. Friends on the call, on here today, you know, they have lost their loved ones. And Alex Kalash, in his presentation to the WHO earlier this year, talked about the humanisation of grief and bereavement. And you know, we have all needed to sit with a lot of pain across the year, but also hope and gratitude. So I live each day with enormous gratitude for the people that are here and around the world that care, and also with a special kindness for the times that we're in. So thank you one and all for being with us. I also just want to, and you'll hear this at every town hall because it's important. IFA will have a global conference in November 2021. It will be in person and it will be virtual. So wherever you are in the world, you'll be able to join friends, colleagues, strangers in community, building community. And there are details on the website. You know, the 5 themes that we have recreated, you know, the first 4 are the action areas of the Decade of Healthy Aging: ageism, primary healthcare, age-friendly cities and communities, long-term care, and the 5th is older people and pandemics. And you will see that it's not older people and COVID-19. It is older people and pandemics, because, you know, as much as we've learnt about pandemics called coronavirus, you know, there are other pandemics, you know, that we need to be aware of. What are the lessons learned? What we haven't learned? What's the innovation? What's the technology? And so across the year, you will be hearing more of this. Here are the sub-themes of the older people and pandemics, adult vaccination. Oh, goodness. My staff want me to keep moving. Thank you. And we've also got a pre-conference summit, Vaccine for Life Summit, Beyond the Pandemic, Driving Policy to Improve Adult Vaccination Rates. So we've also got, we've reviewed all of our pricing structure, and those colleagues, friends that are in the lower and middle income countries, the cost is $180, you know, to come to us virtually. So I do hope that that's, that will be possible for you all. So thank you for allowing me to share these thoughts. And Professor Cole, you are going to close this town hall, this very special town hall, with your remarks. So thank you very much, sir.
Thank you so much. And first of all, I'd like to thank the IFA again for this town hall, having me a part of this town hall. And my message would be the same, that we need to upscale the vaccinations in developing countries in the same way that we have done in the developed countries. Probably go in a more aggressive manner even in the developed countries, but we have a long way to go. And I must say that we must emulate these healthy practices for healthy aging, especially in the older adults, and many other vaccines that are not yet a part of the vaccination programs in various national immunization programs in developing countries. They need to be slowly adopted over time so that people live healthier.
Thank you very much, Professor Cole. It's been a pleasure to have you with us today, and I hope that you'll come back in 2021 and share the progress of the distribution of the COVID vaccine, but the improved uptake rate of adult vaccination. So thank you very much. Okay.
Thank you, everybody.
We have a few more minutes. So does anybody want to share any thoughts as we close off this town hall? Bill, welcome. Dr. Bill Smith, go. The floor is yours.
Good morning, everyone. I just want to thank IFA for these wonderful town hall meetings and for the support that you've given to many of us on many levels throughout the year. I think there's a tremendous job that's been done here, and we certainly appreciate what Andrea has done and what your leadership, Jane, throughout the world has done. So thank you for pulling us all together.
Good. Well, look, thank you, Bill. Special friend and colleague, Bill. So perhaps we can all reconvene on the 8th of January and carry on our building community going forward. So be well, stay safe, and touch those that that care about you and you care about them. So be well. Thank you very much.
Thank you.